Hello and welcome to Doc AT. In today's video, we're diving into the critical topic of distributive shock. What it is, why it happens, and how to respond effectively. Let's break it down together. Distributive shock is characterized by abnormal blood vessel dilation, leading to reduced systemic vascular resistance and maldistribution of blood flow. Despite normal or increased cardiac output, tissue perfusion remains inadequate. Pathophysiology. Endothelial dysfunction. Inflammatory mediators such as cytokines and nitric oxide damage the vascular endothelium. This disrupts its role in maintaining vascular tone and permeability. Dysfunction allows excessive vasodilation and increased permeability, leading to leakage of plasma and proteins into interstitial spaces, also known as third spacing. Mitochondrial impairment. Pro-inflammatory cytokines, reactive oxygen species, and toxins can impair mitochondrial function. Even with adequate oxygen delivery, cellular ADP production is compromised, resulting in energy failure. Autonomic dysregulation. In neurogenic shock, loss of sympathetic tone leads to unopposed parasympathetic activity, causing vasodilation and bradycardia. In septic and anaphylactic shock, the autonomic nervous system may exacerbate dysregulated responses. Microcirculatory dysfunction. In distributive shock, microcirculatory flow becomes patchy and heterogeneous. Some capillaries are dilated and overperfused, while others collapse, resulting in uneven oxygen delivery and tissue ischemia. Subtypes and causes. Aseptic shock. Triggered by infection leading to a systemic inflammatory response and cytokine release. Blood vessel dilation, increased permeability, and capillary leak are common. Pathogens include bacteria, such as E. coli and Staphylococcus, as well as fungi and viruses. Clinical features. Warm skin in early stages and cold skin in late stages. Fever. Hypotension. Altered mental status. Organ dysfunction. Rapid breathing. Diagnostics. Blood cultures, inflammatory markers such as CRP and procalcitonin, and lactate levels. Management. Aggressive IV fluids at 30 milliliters per kilogram initially. Broad-spectrum antibiotics. Vasopressors, with norepinephrine as the first line. Corticosteroids, such as hydrocortisone, for refractory cases. Monitoring of lactate levels to guide therapy. B. Anaphylactic shock. An acute allergic reaction causing histamine release, vasodilation, bronchospasm, and increased capillary permeability. Triggers include food, drugs, and insect stings. Clinical features. Urticaria. Angioedema. Wheezing and stridor. Swelling of the face, lips, and tongue. Difficulty breathing due to airway constriction. Hives, itching, and rapid onset of hypotension. Diagnosis. Identification of the allergen responsible for anaphylaxis. Management. Immediate intramuscular epinephrine. Antihistamines, including H1 and H2 blockers and corticosteroids. Airway management, with intubation if necessary. Sees neurogenic shock. Caused by the loss of sympathetic tone due to spinal cord injury or brainstem trauma. Results in unopposed parasympathetic activity. Clinical features. Bradycardia. Hypotension. Warm skin below the injury site. Paralysis or loss of sensation below the injury site. Diagnosis. MRI or CT imaging to assess spinal injury. Management. IV fluids to maintain blood pressure. Vasopressors such as phenylephrine. Stabilization of the spinal cord injury. Surgical intervention if necessary. Thanks for watching Doc AT. Don't forget to like, share, and subscribe for more amazing content.